we were surprised to see that the high T4 can actually cause brain hypothyroidism. There were some areas of the brain that there was so much T4 that it inhibits the activation of T4 to T3. The cerebellum is a large area of the brain, and in the cerebellum, the excess of T4 inhibited the conversion of T4 to T3. So T3 levels were lower despite having an excess of T4. I find that that's really an eye opening result.
Hi, everyone. Welcome back. And Dr. Antonio, it's a real pleasure to have you back to unpack and hopefully give people some guidance who are struggling with hypothyroid regarding what they can do. Because the landscape, I think, is confusing for people. And you're, in my view, not to sort of gas you up too much here at the start, but you're really the tip of the spear for publishing research that has a ton of clinical utility for patients, especially as it pertains to, should I be on T4 alone? Should I be on combination T4 plus T3? And guidelines for how to know when to do what. Because I know you see a lot of this, as do I. People just get hammered with higher doses and more aggressive therapy. And there's some truth embedded in that canard, if you will. But I think what you're doing, again, is so important and relevant because you're trying to help people understand how to navigate and have guidelines for the appropriate use of thyroid medication. So really excited to have this conversation.
Thanks. Thank you, Michael. It's a pleasure to be here. As you know, I maybe 15 years ago, I've been doing research in the thyroid field for almost 40 years. But 15 years ago, I was really impressed by a couple of patients of mine that were really suffering with hypothyroidism and residual symptoms. And at that point, I decided that I had to change gears in my lab and try to use what I knew about thyroid gland to understand what was going on with treatment of hypothyroidism. And that's why I've been so focused right now on helping improving the quality of life of these patients.
Yeah, absolutely love it. Here's what I'm hoping we can walk through today. I'll just start with kind of an outline, then we can work through it. I'll do this separate once we end the recording. I'll do a quick recap for our audience of our last conversation. But I'd like to start with a short primer on TSH, T4, T3. People probably know that, but just to get them kind of up to speed, have you touch on the deiodinase enzymes, which seems to be a really important, maybe predictive factor for why some people need combination therapy.
Mhm.
Would love to hit an order of operations. First, do this. Second, do that. Third, do this, because this is where I think a lot of people flounder. And by the way, again, where I really appreciate your approach coming from our last conversation, that you're researching deeply into thyroid, but you're also looking at other systems, because there are some cases wherein the solution to symptomatic resolution may not be fine tuning or more aggressive thyroid medication. It might be a cross system like gastrointestinal health or female hormones like we touched on last time.
Right.
Go a little deeper into why T4 alone, like levothyroxine, isn't sufficient for all patients, and then outline the specifics of how someone can go onto combination T4 plus T3 based upon some of your research. And again, try to help give people more definitive targets for lab ranges, converting the dosages, so on and so forth. Hey, everyone, just wanted to insert these few bits here. So Dr. Antonio Bianco, MD, PhD, former president of the American Thyroid Association, currently a professor of medicine at the University of Texas. And I think maybe the most importantly is the research that he's published, which is not sort of just reinforcing the standard perspective of conventional medicine as it pertains to thyroid care, but actually asking questions and trying to better understand how do we best serve people with hypothyroidism who are suffering. So just, I think, a real thought leader and kind of luminary in the space. A few of the key points from our last discussion. One thing that we had, I thought, a very interesting back and forth on was the prevalence of Hashimoto's, about 20% of the population, and the prevalence of hypothyroidism, which are not the same thing. And he and I have a slightly different interpretation, and I go through my thoughts in that other episode, but it's about 5% according to my interpretation, which is very, I think, reassuring because it tells us that 75% of people with Hashimoto's autoimmunity will not become hypothyroid. 75% will maintain euthyroid status, normal thyroid function, and 25% will convert. Important because it's a little bit different than the somewhat fear-mongering perspective you'll see or hear online. And then a few other points that we covered just in quick recap here in case you haven't heard that episode, which again, I would highly recommend. Some hypothyroid patients experience persistent symptoms even if they're on levothyroxine or some type of T4 and have normal levels of TSH. Combination therapy, T4 and T3, can resolve these persistent symptoms. Overtreatment is common and harmful, and many patients actually don't need medications. The hypothyroid diagnosis should be based on labs, not on symptoms, with a TSH somewhere above 7 to 10, paired with, very importantly, a low free T4. And again, remember that antibodies will diagnose Hashimoto's. They will not diagnose hypothyroid. And we also, I think, covered in the last episode, if not, we've covered on the show in the past, that thyroglobulin or TG antibodies are not an accurate and reliable marker. And so the diagnosis of Hashimoto's should rely upon TPO antibodies and or ultrasound. And final point, that many hypothyroid-like symptoms stem from non-thyroid conditions, gut issues, menopause, or other female hormone imbalances, nutrient deficiencies. And so this is, I think, one of the most important things, the flag for people, is to know when to look at other systems of the body and not sort of flounder too long in thyroid treatments. Okay, so there is your recap. So yeah, let's start with kind of a primer as you see it on physiology. Just thinking about the people who maybe have heard of TSH, T4, T3, maybe they've heard of some of these enzymes, but let's start with kind of that high level recap for people.
Sure. So the thyroid gland, it sits in front of your neck, everybody's neck, and the thyroid is actually capable of taking iodine that we eat with our daily meals and use that iodine to make a couple of hormones that are important. One is called T4 because it contains 4 atoms of iodine, and the other one is T3, contains 3 atoms of iodine. So the thyroid's job is to pour T4 and T3 into the circulation, in the systemic blood circulation. Now, T4 is not a real hormone. T4 is the hormone that's mostly produced by the thyroid gland. However, T4 is not active. T4 needs to be activated to T3. T3 is the real hormone. Potent is really the potent hormone that comes from the thyroid gland. So the thyroid produces, secretes T4, and then in multiple tissues outside of the thyroid gland, there's these enzymes that can metabolize T4, and there are a couple of enzymes, they're called the iodinases, that can transform T4 to T3. They remove one atom of iodine, making T3 that's both potent but is rapidly degraded. T4 has a long half-life, stays in the body for about a week, the half-life of T4. T3 is rapidly metabolized. Once it's made, it's degraded rapidly. Half-life, it's 12 hours compared to 8 days. So it's really different. So the issue is when you don't have the thyroid gland, or the thyroid gland was destroyed by whatever disease, autoimmune disease, or surgically removed, or radiation therapy, we don't try to give you a new thyroid. We try to give patients the hormones that the thyroid was producing when it was healthy. So we give T4 and T3. We started 100 years ago giving T4 and T3, both hormones. The rationale being the thyroid making these 2 hormones, we just give these 2 hormones back. Now, once we discovered in 1970 that T4 can actually be converted to T3, then the doctor said, well, wait a minute, why are we giving both hormones? Why don't we only give T4 and let the body, in its wisdom, to convert T4 to T3 as it's needed?
Right.
And that's how he changed everything in the 70s. And rapidly, the idea of giving both hormones disappeared, and T4 became, levothyroxine became the number one or number two pharmaceutical product sold in the United States every year.
Oh, and by the way, if this is helpful, please comment. I'm always curious to engage. Subscribe so you see future videos from us, and share with someone you think this might help. And probably a little bit compounded by the fact that TSH, it's a good screening for overt hypothyroidism, TSH and T4, but it's not going to give you a good read into conversion into T3, obviously,
Right.
and then kind of local tissue availability. And for the audience, just one thing I'll remark is I partially get the rationale of T4 being administered because T4 needs to be carried to all the peripheral tissues and then converted. So there's a physiological rationale for either approach, but like I always say on the show, show me the data. And as you've published some of that data, and there's a growing body of this, we're seeing a increasing signal that some people prefer combination T4 plus T3. And I want to commend one of the things you called out in some of your research papers, which was if we go back roughly 5 years, and this is some of the research we shared in the podcast, I was, and I think the research community was, a little bit skeptical of how often we need combination T4 plus T3 because some of the studies didn't find a high preference when people were surveyed. Hey, we'll try T4, we'll try combination. Who prefers what? There wasn't a strong signal that people universally preferred combination therapy. But to your point, and this is the key aspect, there wasn't a great selection for people in those studies who were symptomatic. So if we take a large group of people all being treated, and let's say most of them report, yeah, I don't have much symptoms. Well, then there's not any benefit to be uncovered by trying the combination therapy. With some of the more recent studies that have isolated for cohorts that were still symptomatic, this is where the signal becomes much stronger. Well over 50% of people seem to prefer that combination therapy.
Yeah, no, it's absolutely right. And there's another aspect. So the study I recently published about preference, I think the results are remarkable because the results have been obtained during the last 20 years. So I didn't get the raw data. The raw data was produced in randomized controlled trials that were done in Europe, were done in the United States. It involved up to 1,200 patients. So in these trials, they were blinded. Doctors didn't know what they were prescribing. Patients didn't know what they were taking, either T4 or T4 plus T3. And at the end of the study, they were asked, which one did you prefer? Not knowing what they were taking. So it's mind boggling that half of the patients prefer combination therapy. Now, who prefers T4 levothyroxine? Only 25%. So you have 25% of the patients preferring levothyroxine, 50% of the patients preferring combination therapy. But you have another 25% of patients that have no preference. So over the years, what we as a society of physicians did was to combine the patients that prefer levothyroxine with the ones that have no preference to say, you see, this is a toss up. Half
Right.
of the patients prefer levothyroxine, the other half prefers combination therapy. So you can give either way because you're going to be, right 50% of the time.
Sure.
But what happens is these are not, you're not putting your hand into a bag and drawing a number, and then you can say randomly, I'm going to get 50% odds or 50% uh, even. These are patients that prefer because there's a biological reason for them to prefer. So if you ask them again and again and again, they will always prefer combination therapy or they will prefer levothyroxine. It's not that today they prefer combination
Mm,
therapy and today they prefer levothyroxine.
mm.
That was a mistake in the interpretation of the data.
Sure.
So what we did was we put all these data together. We confirmed the preference of 50% of the patients. And I think that the approach, what the result is, I should get to my patients and say, listen, you have hypothyroidism. I'm going to treat you. There are two treatments. Levothyroxine, 25% of the patients prefer levothyroxine. 50% of the patients prefer combination therapy. And 25% of the patients have no preference.
Right.
Which one would you like to start? The one that takes care of 50% or the one that takes care of 25%? I mean, I think that this is so intuitive,
Sure.
what we should be telling our patients. And I don't understand why we have not told the patients about this. Why we're not teaching this? Why are we not telling our fellows, our students, our trainees,
Right.
the patients prefer combination therapy and only 25% levothyroxine?
Sure.
I think that's amazing.
And this is something that I think the integrative community has done a pretty ample job with in issuing that recommendation. I do have some fairly palpable concerns that in the alternative camp, there's no upper limit to how much thyroid hormone will be administered, and I'm sure you'll see this where someone's on 100 micrograms of T3. I mean, they're just clearly overdosed, and they're still symptomatic. So like anything else, we want to give a therapeutic reasonably a trial,
Mhm.
but we should see some symptomatic improvement. And if we're not after a few go rounds, then we might be barking up the wrong differential diagnosis tree, so to speak. So there's a balance here, right? Which I know you get, but I'm just saying this for some of the people in our audience who may be a little bit too prone to lean into a higher dose of hormone. And that kind of brings me to this order of operations. Maybe we can try to sketch this out through the body of the conversation. And for the audience, what I'll do once we have a solid list here, I'll create a recap in writing for people because I know our audience takes notes and screenshots to try to make this as applicable as possible. But there would be testing, step one. It seems step two would obviously be some sort of therapeutic trial, and maybe that is a combination therapy where we start. And I want to give you the floor on this in a second, but let me just attempt to kind of give the outline. Baseline testing, your treatment protocol number one. Then I think depending on how that person responds, perhaps we want to look at non-thyroid cause of symptoms like gastrointestinal health and female hormones, and then maybe we come back to more fine tuning. But this is where I'm really curious. How do you think about this? Because we want to be able to kind of disentangle when we fine tune thyroid and when we want to look for non-thyroid. And maybe sometimes this is fairly straightforward. If a clinician is listening, if someone has a lot of gastrointestinal symptoms, okay, we're going to issue GI care earlier on. Or if a woman has a lot of hot flashing and cycle irregularity, we're going to think about integration of female hormone supports. But is there some sort of structure you go through with patients to try to sort this all out?
Yes, absolutely. I think that's an excellent question. So, the first thing when we have a patient that has residual symptoms of hypothyroidism is to acknowledge that this is not in their head. So, I understand what you're saying. I believe what you're saying. I
Right.
know you're feeling like that, and I'm going to try to help. So, that is really important. Sounds so simple, but that by itself goes a long way with these patients that have been rejected by a number of physicians.
Sure.
So that's number one. Number two, we need to confirm that the patient has hypothyroidism. A number, a lot of patients, a lot of individuals taking levothyroxine today in the United States don't have hypothyroidism. They were placed on levothyroxine without a formal diagnosis of hypothyroidism. And we use TSH to make the diagnosis of hypothyroidism. Maybe a parenthesis here: TSH is a hormone that's produced in another gland, in the pituitary gland, and serves to regulate the thyroid gland, the thyroid function. So a high TSH means the thyroid is not working well. So TSH goes up to try to stimulate more the thyroid. A low TSH means the thyroid is working too much. So, don't need to stimulate that much. So diagnosis of hypothyroidism is made with the elevated TSH. Another parenthesis. Some patients have what's known as central hypothyroidism. and their TSH doesn't go up. They have hypothyroidism, but it's because there's a problem in the pituitary gland and not enough TSH is being produced. That's really rare. Maybe 1% of the patients with hypothyroidism have central, maybe 1 or 2%. But if there are 20 million patients with hypothyroidism, 1 or 2%, it's a lot. I mean, it is a rare disease, but because the disease itself is so uh, prevalent, you end up seeing that. So we should always think, well, maybe this patient has hypothyroidism, TSH is not going up, and we need to do something about it. So confirm that your patient has hypothyroidism because we don't want to be treating anyone that doesn't have hypothyroidism.
And that's
Number three,
and just really quick, just to add something there, this is a pretty prevalent problem. We went into a lot of detail in our last discussion on what are the guidelines for making this diagnosis. And one of the things that happens is people will have, let's say, a 1.8 TSH or maybe a 2.1 TSH. Let's say 2.1, probably a better example. And the healthcare provider will say, well, ideally, you should be below 2. And they sort of confuse the guidelines for the TSH level that we want to hit when we're giving medication for how we
right?
screen if someone is or is not
You're
hypothyroid.
absolutely,
And so, like we talked about last time, what ends up happening is people get that incorrect diagnosis and they carry that forward to other healthcare providers. No one double
absolutely.
checks the initial diagnosis. So I just want to flag for people, this is, in fact, one meta-analysis found 37% of people were incorrectly
Right,
diagnosed. So this is crucial because if we can intervene, and I'd say this from a place of passion, seeing so many people struggle with this, if we
right.
can just do a little bit of detective work from their history first, we might prevent them from 3 or 6 months of fine tuning the thyroid,
Oh,
all the while not even treating the cause of their symptoms.
yes, you're absolutely right. I agree with that. So number three, you confirm the patient has hypothyroidism. You have to ensure that they are taking the right dose of levothyroxine. And how do I know that? Because the TSH should be within the normal range, close to 2 or what you just said.
Right.
Now, if all of this is done and the patient remains symptomatic, then before I go into a trial of combination therapy, I'm going to go look for other causes of the symptoms.
Oh, and
And
I'm
why
sorry,
do
not to cut you off, but how long would you recommend someone? I'm assuming this is 3 months or less to sort of go on that dose of T4, maybe make 1 or 2 dose changes to get them at the target level. And then if they're still not seeing a resolution of their symptoms, then you go to this next step.
right?
Okay.
Every time you make a dose change, you should wait 4 to 6 weeks.
Okay.
So it would be like 3 or 4
Roughly
months.
3 or 4 months. Okay.
Yes. Now, and why do we look for other conditions that could result in those symptoms without starting with combination therapy? Because combination therapy requires a lot of coming from going back to the doctor, lab tests. It costs money. It takes time. And you don't want to be using combination therapy if you have anemia, for example. The symptoms that very
Mm.
similar to hypothyroidism, low energy, I feel tired, I'm not thinking right, I have brain fog. Anemia can cause that. Iron deficiency can cause that. A menopausal syndrome, women in their 45, 50 years old, getting close to the menopause, they start having these symptoms that are not easy to distinguish from hypothyroidism. Therefore, we do have to screen for those conditions. And, uh, you know, what are those conditions? What should we be looking at? I think that I made a list here. Uh, I the most frequent ones are iron deficiency. Iron deficiency, iron is used for to make red blood cells that traps oxygen and distributes oxygen through the body, gets it from the lungs and distributes it. So if you don't have enough red blood cells, you don't have enough iron to make hemoglobin, you're going to feel tired and you're going to feel the brain fog. So you should screen for that.
And also
Then,
more prevalent when people have Hashimoto's, the incidence of iron malabsorption due to low HCl, roughly 30%.
Yes. So this is really a combining consequence of having Hashimoto's disease.
Right.
Therefore, we should always start with checking your blood for anemia.
And
And
sorry to keep cutting off your train of thought, but is there a particular marker you look at? Ferritin seems to be the more
ferritin,
sensitive one.
yeah,
Are you finding a level? There's a little bit of debate. Is it, there was one paper by Soppy that found some individuals responded favorably regarding their symptoms if their ferritin was below 100. I've found that to be a little bit too high of a bar. And for me personally, and us in the clinic, if their ferritin's below 30, that seems to more so predict. I think the cutoff for most labs is around maybe 15. But you know, to try to give people some definitive or as close as we can guidelines, what do you think the best way to screen for low iron is?
I think I use ferritin, and I think that I would go with different labs have different
Their predefined
reference.
cutoff? Yeah.
I would go with the cutoff that's provided by the lab.
Okay.
I'm not, I think that different studies will use different labs, and I would, just to trust the reference range that's provided by the lab.
Sure.
That's how we go.
And then also, if someone is iron deficient, they usually, in my experience, notice improvements within a month. So it's not something that's going to take a long time to figure out. Give them a bottle of iron, see them back in 4 to 6 weeks, and either symptoms are improving or they're not. It's not too
Right.
complicated.
Change diet, start eating some
Iron rich foods, yeah.
exactly. So the iron deficiency and the resulting anemia are number one problem. Number two is vitamin B12 and folate deficiency. We should screen for that. Vitamin B12 and folate deficiency can lead to brain fog and low energy. So this is super simple. You're just measuring the blood, the levels of these two compounds, and you can rapidly treat replace the body with these two important elements. Some estimates, we don't have the real data, but some estimates that I get from my colleagues is that when you have patients with residual symptoms, you can actually resolve half of you can resolve the problem half of the patients just by looking at iron deficiency, vitamin B12. There are other issues as well. Menopause is the other leading factor that can be confounding. So you just screen for FSH. You measure FSH, which is a hormone from the pituitary gland that stimulates the ovaries. If the the lifetime of the ovary is getting to an end, FSH is going to be very high. So it's very easy to make the diagnosis. And in some cases, that patient could benefit from estrogen replacement therapy.
Sure.
So I always try to work with a colleague to help in those occasions. Now, sleep apnea, it's another
Mm,
factor that is associated with hypothyroidism. And uh, can cause residual symptoms. Again, coming back to feeling brain fog and feeling low energy. Uh, Being overweight, if you have a BMI greater than 35, you're going to feel tired. You're going to feel, depressed. And that's another factor that can be. And I think that the last one is celiac disease.
mm.
Celiac disease is something that can also result in symptoms and GI symptoms that can lead to anemia, lead to iron deficiency. It's a compounding element, right?
Yep. Absolutely.
So, so we really need to do some work with this patient to identify these most common things and obviously, if the patient has a chronic kidney disease, this is going to be a factor. There are other major diseases that can lead to. So we will
Sure.
have to. That's why the physician needs to do some homework with the patient, screen for all these conditions. Now, after I screened for all of this, and I didn't find anything relevant, then that's when I start with trial combination therapy. And I think that that's important because then we go for the the how can we adjust the replacement therapy with thyroid hormone to make
Sure.
this patient do better. And so it's the last step that I do.
Yeah, and I think just to echo what you said, it's so important to follow this order of operations because these other factors that you outlined, they're going to have multiple, if you will, comorbidities that they cause. Celiac, like you said, can be a snowball, or it can compound and cause multiple other issues like deficiencies and anemias. And if an anemia is unchecked, that may interfere with sleep quality. And so there's this sort of positive, negative
Absolutely.
symptom feedback loop. Um, so I understand for patients, sometimes you'll read a blog or listen to a podcast about the merits of thyroid hormone and you're kind of gung ho. Just you give the process its due diligence. Yeah, and again, remember that these various items, the female hormones or the iron or the B12, if you're hitting the nail on the head, people will know usually within a month. So
That's right.
we're not asking you to sign up for a year of suffering and
It's
waiting.
absolutely yes. The vitamin B12, you can get shots of vitamin B12 and correct the deficiency if you have very rapidly.
And there's some nice pharmacies. I'll just give a little plug to one of my colleagues' companies, Ageless RX. They do online telehealth prescribing for B12. So if someone, let's say they don't have a lot of access locally, then a subcutaneous, meaning a small pinch of belly fat, you have to do an online visit, but it's just something. If someone's watching this and maybe they've been told they could use a B12 shot, but they said, well, there's no one in my area who does this. I'm having a hard time with accessibility. There's more options that are out there that reduce some of these barriers to entry.
Mhm.
Okay, so let's talk about some of the limitations of T4 therapy. And a lot of this I'm just citing from what you've already reported in your papers, but there's been a couple of studies that have found that when people are given T4 and they have normal blood levels of T4 and TSH, some tissues will show adequate level of thyroid hormone. What I have here from one of your papers is the cortex will be hyperthyroid, but the cerebellum will be hypothyroid, which sort of indicates that people might have this challenging time with conversion of T4 into T3. So yeah, I think we've hit on some of the limitations already of T4, but is there anything really salient there that, in addition, that you'd want to remark for people that might help them identify with, like, hey, it's not all in my head. There really is something here that we're learning that is insufficient for some people if we're only giving them T4.
Right. No, I think that's a great point. And so when we treat a patient with T4, remember the thyroid makes two hormones, T4 and T3. When we only give T4, we are e- essentially trusting the body to produce sufficient amounts of T3. And why is that? Because T3 is the one that resolves the symptoms of hypothyroidism. It's not T4. We can give as much T4 we want. T4 per se by itself is not going to resolve any symptom. It must be converted to T3. So uh, the question is, when we treat someone with T4, do we get enough T3 in the circulation? And for the last 50, 60 years, the answer has been yes, of course. But there were some challenges to that dogma, and we consistently uh, came back to that point because our studies in animals, in mice, in rats, were showing me that no, T4 can't normalize T3. And so we looked for different systems, different models in which we could document in patients. And we recently published a study a couple of years ago showing that so we had data from patients when they were healthy, their thyroid was okay, and we had data, and we had also data after years that they developed hypothyroidism. And so we followed before and after, and we saw that if you uh, uh, compare, they have relatively lower T3 levels. There's no way that they can keep the T3 levels normal. Some patients do, but a large number of the patients will have a low T3 level. Now, Sometimes that lower T3 is even below the reference range. They all shift to a lower level, but sometimes, about 15% of the cases, the T3 goes so low that it's below the reference range. So there is an issue with therapy with levothyroxine. We are not normalizing the levels of T3, which is the hormone that's really important. There's another issue. When we look at T4 levels, the T4 levels are high, are really high. So much that half of the patients have T4 levels above the reference range, which is mind boggling. So, this is the situation we are creating. We are giving patients levothyroxine. We normalize TSH. We're super happy because TSH is normal, but TSH doesn't resolve any symptoms. Who resolving symptoms is a job of T3 and not TSH. But we've been told, our guidelines say, give enough T4 so that we can normalize TSH. All right. But as a result, we have an excess of T4 and a deficiency of T3. And I've been hammering the point that this deficiency of T3 is important. I mean, it's not okay to have a deficiency of T3.
Mm.
Recently, we published a study in which we show that the excess of T4 is also not good, is also damaging. That's the study we shared earlier. Uh, Last month, uh, we uh, were looking at animal models, the brain of a mouse, that we reproduce the same thing that happens in patients with hypothyroidism. We made those mice hypothyroid, we gave T4 enough to normalize TSH, so the T4 was higher. And we were surprised to see that the high T4 can actually cause brain hypothyroidism. There were some areas of the brain that there was so much T4 that it inhibits the activation of T4
Mm.
to T3,
Mm-hmm. Mm-hmm.
particularly cerebellum in this study. The cerebellum is a large area of the brain. And in the cerebellum, the excess of T4 inhibited the conversion of T4 to T3. So T3 levels were lower despite having an excess of T4. I find that that's really an eye opening result because it compounds the relatively low T3 level in the circulation and the excess of T4 also damaging some tissues.
And yeah, this might partially vindicate what some clinicians see, which is someone comes in on fairly aggressive thyroid hormone replacement. Their TSH is abnormally low, their T4 is abnormally high, and their T3 is also abnormally low, paradoxically.
Yes.
The question I would put back to you that I think a lot of clinicians and probably patients also are wondering about is if that's happening when someone's on combination therapy, how do you account for that? And how do you typically see this play out? Because I could see this being really concerning. Let's say someone is on desiccated or some sort of combination, but their
Mhm.
levels are still out of whack, right? T4 is still high, T3 is so still low. Do you find most people with the appropriate alteration of the dosing are able to get to normal? And one of the things I also wonder is part of the reason why clinicians are seeing this paradoxical high TSH paired with low T3 when on medication because they're just giving too much T4.
Mm. Well, uh, you said a few things. Let
Yeah,
me
sorry, I know I gave a lot there.
Okay, let's just focus on a few of them. So when you give combination therapy, you are able to normalize TSH, T4, and T3 just with combination therapy, either synthetic levothyroxine plus liothyronine or desiccated thyroid extract. We had this idea in the past that if you treat someone with desiccated thyroid extract, you're always going to suppress TSH. That's not correct.
Mm,
If you're suppressing TSH, it's because it's too much is being given. You have to decrease the dose. No, when you have combination therapy, desiccated thyroid extract particularly, the concern is to have excessive T3. T4 is always going to be slightly either normal or slightly low, but that's okay. Patients can adjust very easily to a relatively low T4. They cannot adjust easily to a relatively high T4. We are used to we can fight back low T4 through the deiodinases. We cannot fight back high T4. So the combination therapy is supposed to bring back T4 from the clouds to the normal range and elevate the T3 from the low level to the normal range. That's the purpose of the combination therapy. You can achieve that using desiccated thyroid extract or synthetic combination. This has been shown in more than 20 randomized controlled trials.
Mm.
So there's no doubt of it. This is not my opinion. This has been published. There's no doubt about it. Now, every time you have an excess of T4, you're going to suppress the TSH. If you have an excess of T3, you're going to suppress TSH as well. So both T4 and T3 can suppress TSH. It's not good to carry forward with a suppressed TSH. We know, based again on a number of studies, that a suppressed TSH means you have too much thyroid hormone in your system. Now, parenthesis, provided that you don't have central hypothyroidism, as we discussed earlier. I
Mm.
always say this because uh, patients with central hypothyroidism feel singled out, feel forgotten, and I don't want to forget them. So when we talk about hypothyroidism, we're talking about primary hypothyroidism, but we can't forget about the central hypothyroidism patients. Now, a suppressed TSH should be acted upon. We cannot carry forward with a suppressed TSH. If the patient is taking levothyroxine, we should lower the dose of levothyroxine. If the patient is taking combination therapy, we should lower the combination
And
therapy.
Antonio, you're considering suppressed below the lab cutoff, which is usually
Yeah, absolutely.
0.45. Okay, just for our audience. Okay.
Yes. If you have below point, now let's put this in perspective. Okay. Patient has strong residual symptoms, cognitive impairment, weakness, tired, brain fog. And the only way that patient can carry forward with their normal life is having a low TSH. Okay, because they tried everything and they need to carry forward with a TSH of zero point 0.2. So here where there's a dialogue between the doctor and the patient. What are the pros and cons of having a suppressed TSH, a low TSH, as opposed to carrying forward with a miserable life?
Sure.
So, and that's obviously we cannot recommend that for 20 million patients,
Right.
but that's why one patient goes to one doctor and they have a conversation about it. And so, okay, if that's the only way you can move forward, is we're going to monitor your TSH at zero point 0.2, or we're going to do some uh, EKGs. We're going to look for uh, osteoporosis. We're going to monitor your bone skeleton, and we're going to make sure that what the bad things that are associated with the low TSH are not happening to you.
Mm.
But be mindful, there's always that slightly increased risk. But the patient said, I better take the slightly increased risk than to not be able to function a normal life.
Sure.
So, so when we say, oh, you can't have a low TSH, yeah, when I say that, I'm talking to 20 million people. However, that does not exclude individual negotiations with patient physicians.
And here's the thing that I get concerned about is a patient is not feeling well and their provider is giving them a suppressive dose of T4 or probably more likely combination therapy of some sort, whether it's desiccated or T4 plus T3 independent. And the patient still doesn't have consistent resolution of their symptoms. They're still struggling. But the assumption then is, well, maybe I had a little flicker of improvement, so I'm just going to stay on this suppressive dose. And these things aren't always so black and white and so clean and so clear. But
Yeah.
the thing I would want healthcare providers to cue in on is unless there's a clear resolution of their symptoms and let me know if you disagree, but unless there's a clear improvement of their symptoms from that suppressive dose, then don't keep them on the suppressive dose. Again, the concern I have is seeing so many people who end up at our office who aren't feeling well, and their other provider is just really, I think, too aggressively using thyroid therapy. So is it fair to say that, kind of like we were discussing with the iron, if it's the right fit for you, you should see cognition improve and energy
That's
improve within a month, right? So yes, are we in agreement there that someone should have a pretty clear resolution of their symptoms on the
yes.
suppressive dose if that's the right thing? And if it's not, get down to normal and don't be afraid that you're going to have an issue if you're not suppressing your TSH with thyroid hormone.
Absolutely. Because there are risks associated with having a suppressed TSH. You should only tolerate those risks if you really have a clear-cut benefit. If you don't have a clear-cut benefit, why are you having the risks? And this is just not right. We should not suppress. This is a very small number of patients that will only function with a low or suppressed TSH. In general, we should not have a large number of patients in that category. We're just giving too much thyroid hormone.
Yeah.
That's it.
So,
I
so
would go back to this patient and make sure that do they have hypothyroidism? Because if you feel bad because you have anemia or you have celiac disease or you have diabetes or you have other things,
yeah,
no matter how much thyroid hormone you're going to give, you're not going to fix the problem.
exactly. So what I would say to patients is take a deep breath, right? And it's not to say if you're feeling poorly, there's nothing that can be done. But if you've given the higher dose of combination thyroid hormone therapy a trial and it's clearly not helping you, come back to a dose that gets you into the normal ranges according to the
Yeah,
labs, and then look for other causes. And that's a really
right.
key thing because, again, we see, and it's disheartening, so many people who've been on a suppressive dose. And we've seen, to your point, people with heart flutters. Maybe it's AFib, but the cardiologist says it doesn't meet the diagnostic criteria, but there's something funky going on with your heart, or they're osteopenic or osteoporotic.
Right.
So, like many things, there should be a fairly clear signal of benefit if it's the right therapy. And if it's not, it doesn't mean we're done. It means we'll keep digging. And sometimes we dig into other
Right.
cross
You're
systems.
absolutely right. Yes, I agree with that.
And the guidelines for dosages or how we would target the dosage to correspond to a given level of the labs, TSH from zero point 0.5 to 2, free T3 mid to upper normal, free T4 probably like the lower half of the range. Is that kind of how you're looking for this? TSH
When
lower
you're
half,
treating,
free T4 upper half, free T3 upper half.
is that when we're treating someone?
When I'm sorry, when we're treating someone, yeah, just to give people sort of the if you're working with your healthcare provider, maybe they're not sure if their healthcare provider is being too aggressive. So how can they cross-reference the targets their healthcare providers using with the medication?
Okay. So I think we should always use the normal reference range. Starting with the TSH, it's a broad range, 0.45 to 4.5 to 5. And I would agree with you. Let's keep it around one, between 1 and 2, because you know that there's sufficient thyroid hormone in the system. The T4, if you're only using levothyroxine, the T4 is always going to be high. Now, if you're using combination therapy, because you reduce the dose of levothyroxine, then you're going to have a T4 within the normal range. I don't aim at having in the upper part of the normal range. I don't think, because T4 is just not an active hormone. So I'm not really concerned about T4 at all. As
Mm,
long as in the normal range,
gotcha.
I think it's sufficient T4 to be converted to T3. I don't want it to be up above the normal range, because then it's
Right.
going to inhibit the endogenous internal production of T3. Now, the T3 levels are a key element here. Do we need to adjust the dose of T3 in combination therapy to looking at the T3 levels? And the answer is probably not.
Mm,
And I'll explain that. I measure T3 because it's a safety thing. I know if as long as the T3 is within the normal range, I know I'm not harming that patient. I'm not bringing the T3 to above the normal range. Now, does it matter if it's in the lower part of the normal range, upper part of the normal range? We don't have the data.
Yep.
So what guides the combination therapy is how the patient is feeling, and it's not the laboratory. I use the laboratory to ensure I'm not harming the patient. I'm not
Sure.
giving too much, but I will make adjustments in the ratio of T4 and T3 based on how the patient is feeling. So, how are you feeling? Uh, the last change we made you feel better, made you feel worse, didn't have any chance. So, that's the conversation.
Right.
Why is that? Because the T3 has a very rapid kinetics, meaning it's absorbed very rapidly, rises in the circulation, and drops very rapidly as well.
Hmm.
So, which T3 level should we use? How do we know what's going on during 24 hours after the patient takes one tablet of T3? If we measure at the very end of the 24 hours, which is the fasting condition in the morning, we'll have one number. But if we measure 6 hours later after taking the tablet, we're going to have another number.
Mm.
And then the only way to look at this objectively is to take one sample every hour during 24 hours and calculate the integrated concentration of T3. From a practical point of view, this is not,
Can't do that. Yeah.
you can't do that. Therefore, we need to go with what brought the patient to us, which is, I'm not feeling okay. So use those thyroid function tests to make sure you're in safe territory. You're not, the T3 is not going to 800 after you take the tablet.
Right.
Okay, we are good. I'm not causing hyperthyroidism, but I will make the fine adjustments based on what the patient is telling me.
Mm. That's a great, and a few follow-ups. I'm assuming that being consistent with the time of day that someone performs the testing probably reduces some of those variables. Is that
Uh,
something that you find helpful?
It should be in the morning,
Yeah,
absolutely.
always in
I
the
mean,
morning.
I like to look at T3 levels before taking the tablet in the morning. So the patient should go fasting to the lab, draw the blood, and then take the tablet in the lab, and
Hmm.
then sit there and wait for 3 hours. And now 3 hours, I know, is the peak of T3 absorption. So the maximum that the T3 is going to get is after 3 hours. Therefore, I have this because I'm concerned with safety, right? I want to make sure that T3 is not skyrocketing. So I like this exercise, this peak of T3 to be within the normal range. Perhaps a little bit above the normal range is okay because very rapidly afterwards it's going to fall into the normal range again.
So
So I like,
you're saying to it would seem to me that we would want someone to do their draw in the morning, but 3 hours after taking the hormone dose. So that's what you're saying. So fasted in the morning, but 3 hours after taking their dose.
yeah,
Okay.
that's right. You don't have
Okay.
to do this all the time. You have to do it once just to make sure the peak of T3 for that patient is not becoming toxic.
Gotcha. Now, some people have also commented that people may need to divide their T3 dose over two administrations in the course of a day. Do you think that's something that has merit?
Absolutely. So let's look at this. How much T3 do we produce in a healthy individuals? So we produce about 30 micrograms. So 30 micrograms is what is produced on a daily basis for an adult, a healthy adult. Now, 20 micrograms is produced outside of the thyroid. 25 micrograms is produced outside of the thyroid gland. 5 micrograms are coming from the thyroid. So very little is coming from the thyroid. And most of it is coming from outside of the thyroid gland. Now, therefore, if we want to give T3 to replace the little bit that was being produced by the thyroid, we can't be talking 100 micrograms. We cannot be talking about 50 micrograms. We are talking about 5 to 10 micrograms territory because, and why do we give more? Again, because T3 is rapidly metabolized. In 12 hours, you lost half of it. So it makes perfect sense to give 5 in the morning and 5 at night.
And would you say
That would,
you kind of max out at, in some cases, 10 and 10, or where do you draw that upper line as a rough guideline? Because I know that both healthcare providers and patients are probably struggling with, well, if a little bit's good, maybe more is better. Hence, like I was
yeah,
saying, we have this message group in the clinic with our doctors, and we'll just compare notes. Holy smokes, look at this person, 100 micrograms. No wonder this person's not sleeping.
well, yes, right. We can talk about that in a minute. Absolutely, because I've seen it as well. So that's why it's important to measure these baseline and 3 hours later. Because let's say the patient feels great with 10 and 10, which I believe is the maximum that I would
Okay.
give to any.
Okay.
Okay. Now, if you're giving 10 micrograms and T3 levels are going to 400, I would be concerned. I would be worried about it, because it's very high. So if you're giving 10, and that's why I want to see what's happening. That's why the 3 hours is important. Now, I think most of the time, 5 or 7.5 in the morning and 5 or 7.5 at night do the job. And again, if you have to go beyond that, you have to start asking questions and
Yeah.
say, are we on the right path here? Or so we really need to have clear cut answers to those questions because if they don't respond to a significant dose, just think about it, 7.5 and 7.5, we're giving 15. We're giving half of what is produced on a daily basis. We're giving a lot of T3. If you're not feeling better, it's unlikely you're going to feel better after with
Yeah.
a higher dose.
Sure. And how often are you seeing people need to have that 2 time a day dosing? Half of patients? Is it a quarter, just roughly speaking?
So uh, most of my patients did not need to have a second dose. However, it is uh, intuitive. It is commonsensical to think that if the T3 is if the issue is that it's rapidly metabolized, you want to split in two to avoid those peaks. Because if we're concerned with the peaks of T3, we want to break that peak in half. So as long as the patient is okay with that, because it is a burden, right? Oh my goodness, now I have to take the second tablet or
Right.
what? It has to be 1 hour before eating. I mean, it
Right.
is like some people can do it, some people cannot do it. So again, it's a negotiation with the patient.
Sure.
If they're
Sure.
taking 5 in the morning, I would not bother splitting 5. If they're taking 10 in the morning, I would just suggest, do you want to take 5 and 5?
Mhm.
Again, look at the peak.
The other component here that I want to flag for people is as T3 is increased, we should be offsetting by decreasing T4. And I think what happens in some cases is they're just kind of tacking the T3 on. I believe you have a certain rule you follow for X amount of decreased T4 corresponding to Y amount increase in T3. What's the sort of guideline you follow there?
So this is just a starting point. The starting point is you reduced by 25 micrograms the levothyroxine dose, and you add 5 micrograms of T3. That's just a starting point. That will have to be customized for the patient. I mean, there are some formulas that people follow. If you want to use the formula, that's fine. But I can guarantee you it's not going to be the final amount that you're going to be giving because you're going to adjust. You're going to work with the patient. You're going to, well, how did that work? Is it better for you or it's not better? So you need to adjust. So I would start by reducing 25 and including 5 micrograms of T3 in the morning.
Alrighty, so let me recap some of the steps here when considering switching from just T4, so something like levothyroxine, to combination therapy. 6 steps. The first, identify if you might be a candidate. So this would be someone in the context of being on LT4, levothyroxine, or something like this that's just T4, and you're having symptoms despite seeing a normalization of your TSH. You also want to make sure to rule out other causes, right? So as part of this first step, before potentially going to modification of your thyroid hormone levels, do a quick audit. Am I a woman with irregular cycles, marked PMS, hot flashing? Is there a history of some sort of malabsorption or GI issue, iron deficiency anemia historically, B12 anemia, gas, bloating, constipation, loose bowels? Maybe there's diagnosed inflammatory bowel disease. Just a few things, and we went into a little more detail in the episode, but to consider and addressing those first, because that might be where the symptoms are coming from. If you've satisfied these criteria, then go to step 2. Consider or reduce the dose of LT4 by about 25 to 30% before adding T3. So if you're on 100 micrograms of levothyroxine, that would go down to 75. Remember, this is important because overdosing is a legitimate thing. And paradoxically, sometimes when people are on too much thyroid hormone, they feel just as bad as when they're on an insufficient amount. So bear that in mind. It's important to offset lowering T4 before adding T3. So then step 3 brings in the T3 at a lower dose. And this is because too much T3 can cause things like insomnia, sweating. 5 micrograms is what Bianco and also the European Thyroid Association recommends, dosed in the morning and reassessing after 4 to 6 weeks. Step 4 would be adjusting the dose as needed. So if symptoms, of course, this is going to be really important. If you're feeling great with the prior dose, do nothing, celebrate, yay. If you're still having symptoms, then consider another increase of micrograms. So this would be BID, meaning dose twice per day. And you can go all the way up to 10 micrograms twice per day or 20 total micrograms per day. Step 5 is monitoring the labs, checking TSH to be between 0.5 to 2.0. Monitor the free T3 and free T4 stay in the normal ranges, the conventional LabCorp, and monitor for hyperthyroid symptoms, racing heart, feeling jittery, feeling sped up, not sleeping well, sweating, just name a few. And then step 6 would be considering alternatives. For example, if you're noticing upon repeat testing that there's fluctuations in the T3, you could consider a sustained release T3 or perhaps a desiccated thyroid hormone like Armour or NP thyroid. This is something that may not be optimal because it's a fixed ratio. And I understand sort of the argument for a natural and naturally derived hormone. People clearly benefit from that, but I suspect some, maybe much of that benefit is because people are going from previously just T4 to now T4 plus T3 as a desiccated hormone. So they feel better, but they might feel even better yet still if we can personalize the T3. And you can't do that with desiccated because it's a fixed ratio. That is the overview for how to walk through this step by step, obviously in collaboration with your healthcare provider if you're looking to dig deeper on what you can do to optimize your thyroid hormone levels. Okay. It's super helpful because, and maybe be a little bit empathetic for the healthcare providers here that I might be trying to issue some cautions to on the one hand. On the other, I get they're trying to help people, but
Right.
that's why I really appreciate you speaking with us. And the purpose of this podcast is to bring minds who are deep in the science and clinical practice here to try to give better guidelines because, we're coming from a place, as you outlined earlier, where conventional medicine's been a little bit resistant to adopt combination therapy. So integrative providers may not have a lot of evidence-based guidelines to steer them, but that's changing. And so that's why I'm excited to bring these parameters to healthcare providers and patients so patients can bring those to their healthcare providers just to have a little bit more of a nuanced and targeted perspective on this. Because again, the big thing I know we both see is people who are clearly excessively dosed. And sometimes that's
Right.
actually leading to equal or more symptoms than
Oh,
being
that's totally
underdosed.
wrong. Yes. No, and you're right. There a change has happened in the last 10 to 15 years. We did a study in which we looked for patients that were placed in combination therapy. That number has doubled in the last 10 years.
Hmm.
Today, we have about 1.4 million patients on desiccated thyroid extract on DTE, and we have about 400,000 patients on synthetic combination therapy.
Mm.
So roughly 2 million patients in the US are taking combination therapy, which is phenomenal. I think that's amazing. I'm extremely happy for that because it's not just, we always think that how many patients are symptomatic, between 10, 15%, 20%. How many patients have hypothyroidism? I know we talked about this, about 20 million patients. So we have 10% of the population of hypothyroidism on combination therapy, which is a very reasonable to all the assumptions we have made so far. Now, if you go to one of these patients and say, if they come to your office and say, how you feeling? I'm okay. I'm taking whatever, desiccated thyroid extract or synthetic combination. Oh, I'm going to switch you to levothyroxine. You know what's going to happen? They're going to switch doctors. They will not switch from a combination therapy.
Sure.
Once they have stabilized on combination therapy and it works for them and they feel better, they will not switch. And I think that that's real progress.
Yeah, I agree. And how do you, from kind of the conventional medical paradigm standpoint, see this shifting? Are other endocrinologists starting to adopt this? What's the ethos there looking like?
I I think there's some science behind it. Of course, there the other groups, in addition to my group, have been supportive of combination therapy. But also, the most important thing factor has been the patients. The patients have a voice and they have been complaining. And I think that some doctors listen to them and, they are actually realizing that it's a matter of choice. It's not a matter of that I can safely treat anyone with combination therapy. So if both treatments are equally effective in terms of normalization of TSH, they're equally safe in terms of health outcomes, why am I not offering both to my patient and let them decide which one they prefer?
Sure.
Especially because I know most patients prefer combination therapy.
Right.
So
Right.
that is the kind of approach that many doctors are taking. And the conventional guidelines are still behind a little bit, but they will catch up.
On the other side of the coin, I do, again, not to just keep making the same point, but have a concern that integrative providers are not adequately either being cognizant of overdosing or they're not adequately reducing T4 to offset the integration of T3. And I was wondering if you can speak, because I know you're looking into this also, some of the dangers of inappropriate long-term use of T4. Is there anything there that you'd want people to be aware of? I know some of this you can discuss, some of it you're kind of about to publish, so you can't say too much. But what can you tell us about what you're starting to see there in terms of the signal and the data regarding some of the dangers?
Okay. Right. So we're finalizing the study. It's currently under review. We were surprised by the results. We looked at a large number of patients. We looked at about 1.5 million patients
Hmm.
with hypothyroidism and compared 1.5 million patients with hypothyroidism with 1.5 million control individuals.
Hmm.
And we did all the matching. It's called propensity score matching. We really created two populations very similar on a number of aspects: age, sex, ethnic background,
Right.
blood pressure. So we control for everything. So, and then we studied these patients for a number of years. So this is a retrospective study. I say we studied, but in fact, we don't study. We just look back
Studied their
and then
charts, so to speak.
well,
Yeah. Yep.
we fast forward 20 years. And what we saw was surprising. Hypothyroidism is normally considered a very mild disease, but in fact, it's a deadly disease. We saw that in these two populations that started to be compared on day zero, and then were monitored for the next 20 years, we saw that mortality rate was doubled in the group
Hmm.
of patients with hypothyroidism.
Hmm.
And even if they had normal TSH, mortality was higher. They had cardiovascular events. They had cerebral vascular events. So the mortality, they had bone fractures. They have a lot of bad things happening to them. The only difference between these two groups was hypothyroidism. One had hypothyroidism, and we're talking about 1.2 million patients. We're not talking about 100 or
Right.
200. These data are very solid. So first, the idea that hypothyroid is a mild thing, that you just normalize TSH and say goodbye, that should change
Mm.
because that's not correct. It's a serious disease, can lead to very bad consequences. But then, using the same method, we compare patients taking levothyroxine with patients taking combination therapy, either by desiccated thyroid extract or synthetic thyroid hormone.
Mhm.
But obviously, we don't have 1.5 million patients there. We only had about, I think, 90,000 on each group. So 90,000 patients on levothyroxine, 90,000 patients on combination therapy. Again, we use propensity score matching to create two very similar population and follow them for 20 years.
Right.
Amazingly enough, the individuals taking combination therapy had less mortality,
Mm.
less uh, heart problems, and less cerebral uh, hemorrhage
Mm.
problems. So we are going to publish these results. So we wanted to show that the idea behind the study was to show that combination therapy wasn't doing any harm. But in fact, we end up finding out that if you are in combination therapy, you're actually less likely to have serious negative outcomes. We're
Wow.
trying to understand why that is, but that's really a changing. I hope this can be reproduced in other studies, but this is pretty impressive.
That's remarkable. Yeah. Um, yeah, I mean, obviously pretty huge implications, especially if you've gone through the rigor of the controlling, right? Because one of the first things I think someone would maybe point to is, well, it's the comorbidities that's driving the increase, mortality. If you've controlled for that, and I mean, no controlling is perfect, but I mean, we can certainly reduce the
Right.
noise in the signal quite significantly if we control as best as we can. So, wow, that's remarkable.
Yes, I'm looking forward to. We didn't get the first round of reviews yet, but this is. I'm sure it's going to be published, and I hope it will help patients.
Something else I'm wondering, this is maybe getting a little bit into the academic researching weeds, but has there been a lot of pushback when you go into peer review? This is something that when we published the couple of papers on thyroid that we put out there, surprising amount of pushback when we challenge sort of the normal concepts. And I found myself saying, did the peer reviewer, the one in particular, did this peer reviewer even read the evidence supporting our claims? Because it just felt like they had their opinion and there was a knee jerk criticism of our position without looking at the evidence supporting our position. So I'm assuming
Right.
you're getting a heck of a lot of slings and arrows as you're trying to do this.
I have to say that I'm always surprised by reviewers' comments because the peer review is an interesting process in which they're anonymous, right? Anonymity releases them from saying bad things or criticizing you bluntly, which is the purpose of the peer review, right? So in general, uh, there are a couple of reviewers that, by the way they write or by the rationale they use, I already know who they are, and they are always very negative about the idea of using combination therapy. Very negative. But this is life. I mean, everyone has the right to have their own opinion, but my answer is always look at the facts. Just look at the facts. Read the papers, look at the facts, and the facts will bring you to an objective,
Yeah,
resolution. We really, that's why talk is good, but we really need numbers. We really need solid data. I
sure.
think that mortality data, for example, is going to
Yeah. Hard to argue with
change
that. Yeah.
that
Boy.
exactly. Because when you're talking about brain fog, you're talking about Oh, I'm tired of those questionnaires. Those are very soft
Yeah, they're
targets.
very subjective. They're very easy to sort of criticize. How accurate are these quantified? Are they caused by lifestyle stress or aging or whatever?
But when you talk about mortality, it's very serious because it's a binary thing. Alive.
It's the pinnacle endpoint, right?
Yes, exactly, exactly, absolutely.
Alrighty, and here is a concept summary. Firstly, and I really appreciate this about Dr. Bianco, acknowledge someone's symptoms, right? These things are not in your head. There is a reason for them. And at the same time, confirm the presence of hypothyroidism. This is so important because, like we've discussed on the show in the past, some very compelling and high level or highly accurate, reliable data has shown that as much as 37% of people have been incorrectly diagnosed. So we want to make sure that we don't miss this. And before we start marshaling resources and time and attention toward thyroid, we want to ensure that we're actually barking up the right tree, so to speak. The second step or second concept here, ensure you're on an appropriate dose of levothyroxine, that your TSH is between zero point 0.5 and 2. In some cases, the dose is insufficient, and in some cases, the dose is excessive. So, a fairly easy thing to do with a blood panel. Thirdly, rule out other causes. And again, I really appreciate this about Bianco's perspective because it's possible that you will not need to tinker with the inclusion of T3 if you address an ongoing issue in the gut or with female hormones or address a prior anemia. By the way, anemia risk increases in those who are hypothyroid, or you address untreated celiac, just to name a few, but those might be some of the most high impact and most common. Next, monitor your symptoms while on combination therapy and use labs as a safety measure because it is possible two things could be happening at once. You could have other causes of gut symptoms, and simultaneously, you could need to fine tune your dose of T3. If you're only using your symptoms as the barometer, it's very easy to overdose. Why? Because symptoms don't get better, and people assume, well, I need more hormone. And we see, like I said numerous times during the body of this interview, so many people who come in with alarmingly high levels of blood T3. Again, why it's so important to rule out some of the other causes first, because this mitigates noise in the signal, so to speak. It reduces non thyroid symptoms, which have a lot of overlap with thyroid symptoms. Next, adjust T4 and T3 appropriately. Remember, you don't just stack T3 on top of T4. You want to offset by decreasing by about 25% the T4 to accommodate the initial dose of T3 of 5 micrograms. And if you're newly diagnosed, Bianco recommends starting with T4. I've underlined this next point that you can start with T4 or combination therapy because I think there's enough data now, given the meta-analysis that Bianco published, that over 50% of people actually prefer combination therapy. So with that sort of registering number, I think it's not unreasonable to consider starting either with T4 or with combination therapy. And I think that's probably the conclusion Bianco will more formally come to, but I can appreciate his perspective. At least I think if I can try to read his mind, he's trying to be as conservative as possible and not get too far ahead of the data. And certainly, I think someone in his position, that's understandable. He's trying to champion this new message, this new way of thinking. And the conventional system is probably going to be very eager to cut him down if he's not conservative and very thoughtful. So, there's some interpretation there, but do with that what you will. And remember that some will do well on T4 alone, but it does seem that the majority of people, now, whether that majority is 50%, 51%, 75% is debatable, but will require and feel best on combination therapy. Okay, there you have a summary of those key points. Awesome. And Antonio, anything that you want to close with? I know you have a book, so please mention the book for people before we wrap, but any other thoughts? I mean, there's, I think, been a really, and thank you again, rich conversation regarding thyroid and giving people what I hope is really that reasonable balance between, we want to be open-minded on the one hand. We don't want to just scoff at people and say, well, if it's, if you're not feeling better on T4, then it's all in your head. But we also want to be careful not to go too far into aggressive thyroid dosing. And I think you've beautifully struck that balance. And I know that you've helped a lot of people through this conversation. But again, any closing thoughts? And then where would you want to point people to if they want to hear more from you?
Well, I think I'm happy the way things are progressing over the last 10 or 15 years. I think that we came a long way. The guidelines have changed. They accept combination therapy. They're being rewritten right now, the American guidelines. I hope they capture that. They
Mm,
can't ignore the fact that 2 million patients are taking combination therapy. This is it's you can't just negate that. And I think that we're learning more and more, and to the point that we just discussed, we need data. We need scientists, physician scientists looking into this and producing data because only data will help us understand. I think that we now understand that levothyroxine therapy, it does not normalize everything. The only thing that levothyroxine therapy normalizes is TSH. It doesn't normalize T4. It doesn't normalize T3. That's there for for a large number of patients.
right.
That's important. We know intuitively that low T3 is not good, but now we know that high T4 is also not good.
Yep. Yep.
And I think that that's important. And I'm really looking forward to us publishing these large studies in which we have solid data of beneficial effects of combination therapy over levothyroxine therapy. And again, it's going to be one study that needs to be reproduced in other places, in other parts of the world. I mean, it's just one, but I think we are going in the right direction. If patients want to hear more from me, I mean, I think that they have to look at these podcasts. There are a couple of podcasts, a few podcasts that I participated. I wrote a book about 2 or 3 years ago. It's called Rethinking Hypothyroidism, which tells the story of how my mind changed about this thing. And the book, I tried to write this book for both physicians and for patients. So it was challenging because you can't give a lot of, but I think that I feel very uh, humbled by the feedback I received. And it was just amazing. Hundreds and hundreds and hundreds of emails from patients
Mm.
thanking and really appreciating the work that has been done. And I'm really happy about it.
It makes all the hard work of getting a book out there worth it.
Yes, absolutely.
Awesome. Well, again, Antonio, I always really enjoy our conversations. I'm sure we'll have you back. Let's try to maybe chat once a year. I feel like that's a good minimum with everything that you're involved in.
After that study is published, I need to come back because then I'm
Yes,
going to show all the graphs. That's definitely
that would be
important.
that would be fantastic. When is that anticipated to publish?
Maybe 2 or 3 months.
Okay,
The
so
you
yeah,
know,
maybe we'll plan for late this year, early next year. But yeah, that's
yeah,
such an
absolutely.
important study. I cannot wait.
Okay.
Awesome.
Thank you
Well,
very
thank you
much,
again. Been
Mike.
a pleasure. Really appreciate it.
Thank you.